Okay, so welcome to the fourth instalment of the Wendy webinar lunchtime series. Today, I'm really excited to introduce Dr. Alexandra Pietsch.
Yes, well done.
Yeah. Dr. Ali has just started working as a fellow GP this year after finishing her exams last year in 2020. She has a special interest in women's health and is now dividing her week working between a general practice clinic in Brisbane and being a reproductive health specialist and working in a reproductive health specialist clinic. Ali has additional qualifications in pediatrics, family planning, and also IUD insertion procedures, so that she has already been able to start working as a GP with special interests, even though she's only newly fellowed, which is fabulous. When she's not working, she loves to be outdoors with her family and her crazy griddle, who is never tired. Thanks very much, Alex.
Hi everyone. So as Rach said, I have just recently started working as a fellow GP, but as part of that, we kind of do a couple of years as a registrar and basically do the same thing. So I've been in general practice for about 3 years now. So I was just going to go through kind of the pros and cons, how I kind of made my decision to get here, and also the pathway to get to general practice. So basically, I just thought I'd show you, like, this is the list of what I did yesterday. So it's pretty standard day. You do a bit of pregnancy stuff most days, and I do particularly because it's my thing. Someone who walked in and did an ECG and they had AF, baby checks. Drug seeking is a big issue in GP, so you have to kind of be onto that, which I'm pretty naive and not very good at, but getting better. Mental health, a lot of that. Centrelink forms, the work cover stuff. Basically, it's a pretty good mix there yesterday. A couple of things that are a little bit beyond me. So I'm married to a medical registrar, so I kind of phone a friend for a few things like that. The hypophosphatemia was one that I was a little bit confused about. And then obviously at the moment we are doing a lot of COVID related stuff. So we're the first protocol for all that stuff, and it gets a little bit exhausting. A lot of people with colds and flus who want to be seen and aren't used to not being able to come in and have to get a swab first. So that's something that you will see a lot of if you were going to do general practice placements at the moment. So I guess I just thought I'd talk to you about the bits that I love about GP first. So it is very, very flexible. So as like when you're a registrar, you're a little bit more, I suppose, bound by the training requirements and the days and times and things that you have to work, but you still can speak to your practice manager and kind of do your thing. But once you're finished, you can literally just choose whatever hours you want to do. So you're an independent contractor. You just say, look, I'm going to work these days, these times. You want to change, you change your appointment book yourself. It's very, very flexible, which is fantastic. And kind of on the same vein, you've got the family friendly training pathway. So I've got friends who've stopped and had kids multiple times throughout the training and then gone back to it. You can work very, very part-time. It's about a minimum of, I think, 14 hours a week or something for training. So pretty flexible. I'm not sure how that compares to other training programs, but I'd suggest it's probably one of the most family-friendly pathways. Extremely employable. So I had about 4 or 5 job offers, like straight up from fellowship. People sending me Facebook messages, like from practice managers from other clinics, like in the city, Brisbane. You don't really need to fight for a job at all. Like everyone wants GPs. So that's good, because I know in the hospital, particularly when you're finished, there's a big bottleneck for getting a training place, and a training place, but also when you finish, getting a consultant job. So that's been really nice. You can really subspecialize within general practice. So I've got a colleague who only does skin. He works at skin cancer clinic on the other days and here a couple of days. I do women's health stuff, which I can talk a little bit more later, but I don't limit the patients I see in general practice. I don't say only women or whatever, but I do tend to attract that kind of clientele, I suppose, and then work at the women's health clinic on the other days. So you can really choose what you like. There's a lot of different sub areas. Some people do addiction medicine. There's a couple of GPs at my clinic who do occupational, like pre-employment health checks, travel medicine, although not so much now, but there's a lot of options. You know a little bit about everything. So, someone will ask you a question, and it may be that person is a friend who's a specialist now, and it will to you seem like that is so obvious, because you do have that expectation that somebody could come into your room and ask you literally about anything. So you tend to just learn on the job, and it's a good way to keep breadth of knowledge in medicine, which it can also be scary on the flip side, because you never know what someone's going to come in with, and it could be literally anything. But yeah, you feel like you kind of maintain a finger in all the pies of medicine, which is nice. The human connection. So obviously it's probably one of the best areas for continuity of care. So, you know, I have a family who I see the great grandma, you know, the grandma, the mum and the baby, and, you know, that kind of thing, and seeing them over and over, you know, over the weeks. And I've had a few patients who followed me around to my different clinics as well that I've been at since training. So like that's been really nice as well. Just having that, you do really form these relationships, and that can be sad as well when bad things happen to those patients, but I like that. And so, yeah, contributing to every aspect of a patient's health. Same thing again, because you do know a bit about everything. You could be organising their scopes and, you know, dealing with their ingrown toenail surgery and doing their pap smear and whatever. So you kind of get to be a part of everything rather than just having your one organ and then checking out. So I like that. You do feel part of the community. Like we've been doing the COVID vaccine clinics. So, you know, on the Sunday, you know, I'll stand here for 3 or 4 hours, and, you know, you see 200 people and you say hello to everyone, and they'll bring you a coffee, and you do get to know the local area and the local community members, I suppose, and that's nice. And we have my boss as well. She does a lot of community outreach stuff. So we do like puberty talks at schools and, you know, that kind of thing, which is really good. If you're into this, which I don't know that I will ever be, but certainly if you did want to start your own clinic, or, you know, get into some sort of business investment type of situation, you definitely can do that quite easily with general practice. Like the money is fine. It's certainly, you know, the poor cousin of all the medical specialties, really. But in saying that, you can earn a really good wage, as like what I do with kids and women's health and that kind of thing, longer consults. And so it's not as well, I guess, rewarded monetarily, but I find it like emotionally and, you know, professionally satisfying. But you can certainly live very, very comfortably on a GP wage. And I wouldn't, if you're, you know, you don't want all the fancy things, but you're happy for a very comfortable life, then yeah, I wouldn't worry that you're not going to earn enough, because you can earn quite a good amount of money in GP as well. So I suppose within the good, so I look at it as, you know, you're working to live, not living to work so much. So I love medicine, but also like I have a lot of other interests outside of life, and I preferred, like, I work because I have to work and I want to do something that I enjoy when I'm at work, but it's not my life. So that's something that GP is really good for. As I said before, you are an independent contractor, so do whatever you like. Work, say I'm not doing these weekends, I'm going on holidays for 4 months, that's your prerogative. No night shifts, no on call, unless I know rural GPs still are on call a little bit, but certainly for where I am in the city, we have the after hours doctors from 6 o'clock, so we don't have any on call at all. As I said before, very employable, so you can go wherever. Like if I wanted to move rurally or move to the Sunshine Coast where my family are, or stay in the city, or even overseas, my husband might do a fellowship in the UK when things settle down. I could easily get a job over there with reciprocal, like, you know, recognition of general practice training. So it's pretty flexible and pretty great that way. You finish quickly. It's only really 2 years after your intern year, 2 years after your second hospital year. So I'll talk about that in a little bit, but it's pretty quick really, compared to other training programs. And then, yeah, you get your exams done, and then you just get to live your life, and you're still relatively young, and, you know, time for all those other things that are important. So if you do want to still live to work as a GP, you can very much do that if you like. There's always shifts available. There's locums, which are quite lucrative. You can study and do an extra qualification. So as I mentioned before, we've got, you know, skin cancer, women's health, which I do, pediatrics. I also do an extra qualification in that. Occupational health, travel med, sports med is quite good as well. There's a few really good, they're often ex-physios, but don't have to be, who get really quite a good following around here. Sexual health, there's people who've done extra training in parenting and do like 1 hour consults all day, every day, and just do that kind of stuff. You can do like GP focused counselling, which has been something that's got a lot more popular with COVID and I suppose the significant demand for psychologists, and so a lot of people relying on GPs for that side of things. And also I have worked with a previous colleague who was a breastfeeding consultant and did a lot of lactation stuff. So that's just the people that I've come across. There's lots of other things as well. You can also join advanced training programs. So if you've got a fellowship FRAC GP, there's a few, there's not many, but I've listed in there: sexual health, palliative care and addiction medicine, which are with the FRACP college. You can actually join into their advanced training program after you've finished your GP training. So I had actually had a little bit of a think about maybe doing sexual health at some point, but I've decided against it for a few reasons. But you certainly can actually become, I suppose, like a specialist, as it were, after finishing GP, which is quite good if that one of those areas is what you're interested in. You can also do stuff on the side. So like they call it Gypsy, GP with special interests. So I do a couple of days a week elsewhere, working in like a kind of gynecology type clinic. You can also work for Queensland Health. So there's a bunch of like gypsies in Queensland Health. So you can work in the breast clinic. You can do you can just do like marinas all day inserting IUDs. There's a bunch of kind of things you can do. I think there's a couple of jobs in antenatal clinic as well, like just seeing the high risk pregnancies as a GP rather than an obstetrician, but they still prefer to have a doctor that isn't a resident or a midwife for those kind of things. So you can definitely slot in and get paid quite well as SMO rates with the hospital and get the, I suppose, all those entitlements and things, leave entitlements, maternity leave, sick leave, that you don't get as an independent contractor and GP. So having a side hustle is good. You can also pick up ED shifts. So you may notice when you do your ED rotations that there might be GPs working like subacute clinics and things, sometimes on the weekends too. So yeah, you can definitely be an ED doctor without having your ED fellowship per se. And then surgical assisting is very common. So a lot of people do that even through their registrar years. So you just hook up with a private surgeon and do whichever sessions per week will suit you, because you can work fit your registrar hours into 4 days and even full-time training, and then do 1 day surgical assisting, which is a nice little boost as well. And if you are interested in gen surg or ortho or whatever, keeping your hand in there too, which is nice. And then you can also go rural. So you're always looking for rural GPs. I've got a friend who's done it relatively recently and loving it. You an SMO with Queensland Health, but also you get your rural loading, travel allowance, very, very lucrative if that's something that you're interested in. And you can do that pretty soon after fellowship. You would also obviously be on call and having to round at the local hospital, but half-time hospital, half-time GP, which is, even for a few years, something that can be quite interesting to do. Now, the bad. So clearly, nothing is always perfect. I've talked about all the good things, but there certainly are a fair few downsides and things that I do, I suppose, I guess, think about as, oh, should I have not done GP? So we are definitely, we don't earn that much when you look at comparative wages, but we certainly, in a general society, very much, high earning individuals as general practitioners. But certainly if you look at your surgeon colleagues and things, you'll think, gee whiz, should have stayed at the hospital for a little bit longer. That's not really an issue unless you have, a lifestyle where you feel like you need that money. You do a lot of unpaid work. So there's no overtime. You're an independent contractor. You will have piles of paperwork at the end of the day that you just have to do. And the only time you get paid is when you are sitting with the patient in front of you, because the patient pays for their consult. And that's how you get paid, is a percentage of the billings, which you generate through the day. So if you're just sitting at work, but there's no patients booked in or patients cancel, or you need to do, a big referral letter or checking your results, all that stuff you just have to do in your own time, which, if you're slow or try and be thorough, which I fall into that trap, you can end up doing a couple of other hours a day of unpaid work, and there's no one to cover that for you because you're independent. There's no leave. So you're an independent contractor, you're a sole trader. So sick leave is just, you don't turn up, you don't get paid. Same for maternity leave, holidays, all that stuff's public holidays. So that is definitely a big downside for a lot of people. As I said, you can try and kind of dabble in, Queensland Health jobs and things, or being an employee where you can at least have that for some of the time, but certainly in just standard general practice, no leave at all. You can feel like a community intern. So you just get all the discharges, GP to chase, you're on MCS, GP to do this, GP to do this. You'll get just calls from people, like basically you can sometimes feel like you're not really a valued colleague, or feel like you're not really a doctor, because you just get asked to do menial things because you're the GP. And I remember clearly being in the hospital and being so busy and thinking, you know, that'd be great, let's just get the GP to do all that stuff. Then, you know, when you're on the other side of it, you realize that actually you are extremely busy and you feel like you're not respected when you get asked to do that kind of thing. So, you know, you just have to, I suppose, establish that good relationship with your local specialists and things, and that kind of tends to be better as you get further along in your career. I suppose linked to that, a lot of people say, oh, you're just a GP, you didn't want to specialize, which, you know, to be fair, like the patients that come and see you and who respect you, like, you know, they'll shower you with appreciation and, you know, you're an amazing doctor, blah, blah, blah. But people who don't really understand can think that you are just kind of one of the dodgy doctors who didn't make it through whatever else all the specialists did, which can be, you know, a little bit depressing sometimes because, you know, I was certainly very high achiever at uni and as a resident, but I just wanted to do GP. That is what I chose to do. So, you know, that's one of those things that the colleges tried to work on with their Specialist in Life campaign, which you may have seen, which wasn't really very well received by the GPs generally because it cost us a lot of money with our RACGPs. But anyway, so that's something that we're trying to work on. The environment that you're working in can be a little bit isolating. You are, like, I'm at work now, this is my room, but you're just in your room by yourself all day. You rent the room from the clinic. Certainly there's nurses and other doctors around, but you do find that you'll see someone in the corridor of like, oh, hey, like, haven't seen you in 2 weeks. You've both been there, but just in your room doing your thing, patients in and out. So it's not that nice kind of ward round, let's all get coffee after ward round, let's talk about the list, let's bounce ideas off each other. That was a big adjustment for me because I'm very much like a social person who really enjoys working in a team. It is dependent on the clinic that you're in, obviously, and there are, you know, team meetings and things like that, but it definitely is on the whole, like, probably more isolating than many other environments as a doctor. Yeah, so just back to the money. So Medicare rebates, they haven't really increased in a long time compared to inflation and all that kind of thing. So we are, you know, struggling to be able to bulk bill anymore. Really, it's not feasible. Your clinic would have to be shut down because you wouldn't really be able to pay for the electricity and your receptionist and things. So, you know, having to charge out of pocket fees and things, that's, the patients don't like it. And so, yeah, there's definitely that kind of strain there. Making clinical decisions every 15 minutes. So your appointments, like even in a private billing clinic, which goes slower, so not, you know, you're not doing 6 an hour, you're doing 4 an hour, you're still resetting patient in front of you. They're going to tell you bits of information. You've got 15 minutes to make an assessment, make sure they don't die, that you haven't missed something major, and then send them on their way. And so that can be something, particularly when you're first starting as a registrar, that's quite hard to get used to, because you can't just say, oh, look, you know, we're just going to shut the curtain and leave your 4-bed bay and go and have a little look at the desk, look up a few things, then come back. You're like, they're there, you're there. You have to know what you're doing and just make a decision. You can get them to go and like do a urine test. I definitely have done that a few times, but I want to quickly Google something. But generally speaking, it's like, you know, you feel that pressure to be making good decisions a few times an hour for a different patient. So that's new and different from the hospital. Oh yeah, the last point, specialists can just say, oh, look, you know, there's nothing more for me to do here. Like, go back to your GP, goodbye, sorry, no input. And then, but GP, you can't say no. Like, they can just come and see you 3 times a week and you can have absolutely no further input. You know, we call them, you know, colloquially heart sink patients, which will, you know, they've got either a chronic disease, which they don't want to acknowledge, or that they don't want to make the lifestyle changes they need to, or whatever. You know, the specialists can very easily say, don't need to see them again. Whereas, you know, the buck stops with you. So same with mental health stuff. At the moment, psychology, psychiatry, we're talking like 12-month plus waiting lists. So, you know, you'll have the same patients coming back who you feel like you've exhausted your ability to manage, but, you know, there's no one else. So, yeah, so that's kind of the things that I find hard about general practice. So I just thought I might have a quick chat about, like, how do you actually choose what you want to do, and how did I get to be here? So I kind of sat down at some point, probably was still in medical school, and just thought, like, how do I actually want my day to look? Do I want to be in a clinic? Do I want to be doing ward rounds? Do I want to be in a theatre? Do I want to be, you know, in an office doing non-clinical stuff? with our patients. And so if there's a certain thing that really appeals to you, that's an important consideration realistically, because you're deciding on something that you are going to be doing every day for a very long time. Can you happily do the bread and butter pathology? So, if you're a surgeon, you are going to see a lot of appendicitis and a lot of gallbladders and incision of drainage of abscesses. Like, that is the reality. And are you happy enough to do the bread and butter, 80% of the time? Or does that stuff drive you absolutely bonkers? Like endocrinologists, they're going to do a lot of diabetes. Some of them don't really like that. So that's just something to think about. Like, while there's all the cool and exciting parts of the specialty, do the things that, common things happen commonly, and are they things that you will enjoy over and over again for a long time? Do you like talking to people? Like, some people actually just want to do medicine but don't really want to talk to people. So do you want to do pathology or potentially radiology? They do obviously have interventional radiologists and things, but are you wanting to be at the coalface, like, as I say, 4+ patients an hour, or doing a round where you do slow rounds, so you might see a few patients in a day? And how patient are you? Like, can you deal with annoying patients who don't follow your instructions time and time again, or are you just going to get frustrated? You have to have a long fuse to work in, like, a general practice or, internal medicine, that kind of thing. Do you like working alone or in a team? So obviously, as I said before, I work alone most of the time. Do you prefer to be doing big group ward rounds in theatre with people all day? Do you prefer pure science? So like hematology, like their blood film says that they've got leukemia, cut and dried, that's it. Or do you like kind of that more diagnostic process and the talking medicine, and maybe never finding a good like a true diagnosis? But there's definitely a difference in the specialties in how much you're doing science-based versus talking-based, hypothesizing-based work. Do you like study and research? So a lot of specialties, you will need to have a bunch of publications on your CV to even be able to be considered to get an interview for the advanced training program. So if you absolutely hate that idea, then probably don't do something that needs you to have a PhD before you get on. How much do you love money? I've touched on that before. It is something to think about. If you really need fancy things, then you have to think about that. It's really not a priority for me, and I'm very happy just to be comfortable and enjoy my life. Do you value control over your own life? So I was talking to my husband about this PowerPoint, and that was his input. So certainly he sees how much control I have now. If I say I'm not going to work this Thursday because I want to do something, friends coming from overseas, interstate or whatever, I'm just not going to work, cross off my book. Whereas he is bound by a roster. So he's on night shifts, nothing you can do about it at Christmas 4 years in a row, whatever. Like, he's a number in the system. He has no real control. He got sent to Rockhampton in the middle of COVID last year, just got sent, we got a week's notice. So, do you want to have control? Are you happy just to kind of go with the flow? I'm not someone who really likes going with the flow. I like planning things in advance. So that was not something I really enjoyed when I worked at the hospital. Do you cope with minimal sleep? So this is something that I do not do well with. Night shifts, I used to vomit most night shifts. Like, I just, for whatever reason, my body didn't love it. If you are someone who's really good at staying up all night and just pushing through, then you're probably okay. But you do have to think about that. If you're on call or being a surgical registrar, doing a specialty that has lots of night shifts, you will have that toll on your body, and whether or not you actually can physically cope with that is something that most people don't really think about. But when you're actually living in it day after day, you do need to think about it. And how competitive are you? So some specialties are cutthroat. You have to be a little bit brutal, and they're becoming more and more competitive these days, whereas you'll get a lot of people passing through the advanced training program, but then there's no consultant jobs. So do you want to have to fight things out for a very long time, or are you happy just to kind of be like, look, I just want to work, do my thing, and go home and live my life? So yeah, they are the kind of things that I think you should consider, because it's not just I like this specialty because it was fun when I did the rotation. There's a lot of kind of practicalities to it as well that will impact your life long term. So if you want to be a GP, how do you become a specialist in life? Well, it's changing. This picture on that slide, that's the general practice guide. If you just Google that, there's a big PDF document which lays it all out. I'm not going to go through it now, but basically the stepwise way it works. And the thing is, it's all changing. So we don't actually have good answers as to how it's going to look in the next couple of years, but it's just specifically from 2023. So the cohort that will be coming in, not the very next one, but the one after, things are going to be very different. So previously we had regional training organisations which would manage it, and the college would be taking a backseat role. Now the colleges are taking over, and nobody's really been told what that will look like. So I won't spend much time telling you because it may all be wrong. But basically at the moment you sit an entrance exam. I did mine in intern year. Then if you get on the program, you do your 2 years of hospital work. So your intern year, then 1 year as a resident. And then from there, you do your 2 years of GP placements. And throughout that time, you do compulsory education components. There's a couple of assignments and there's some fellowship exams. And then after that, you're finished. So, and there's 2 colleges, which will give you like a fellowship in general practice. So ACRM is more like the rural medicine college, but FRICGP does a rural stream as well. So if you're interested, you can have a read through that guide. It will tell you everything. But this is just a quick flow chart. So once you finish your 2 hospital years, the first one, that's ACRM, and you do basically 1, 2, 3, 4. So yeah, this actually, this might be a little bit, so yeah, this probably should say, so the following applies after successfully completing intern year. So 1 year of intern, and then year 1 of the program is your like JHO year, for example, there, that core clinical training time is that's not your intern year, that's the second year of hospital training, just to mention there. So you don't need to do 4 years unless you're doing rural. Rural adds another year, but I didn't do rural training. So that's why I was done after the 2 years of GP terms. So just what I did, I was an intern in 2016, I did my exam, 2017, JHO on the program, 2018, I just decided to take leave. I asked GP College, can I have 6 months off? We wanted to go traveling. They're like, yep, cool, that sounds great for your general life experience. So I was just on pause, went overseas, came back. Then I decided I'd started full-time with GP, and then I just wanted to do a few other things. So I was doing a diploma of child health and a national certification of family planning plus IED training. So I ended up just slowing down my GP a little bit so I could go to those other placements that I needed to go to. So 2.5 years doing that. Then did my exams last year. There was a bit of delay with COVID. Our exams got cancelled a couple of times, and then the paperwork took about 3 or 4 months, but finished fellowship earlier this year. And nothing really changed in my day-to-day life because I was still working in a GP clinic. It was just that I was getting paid as a fellow once that all kind of came through. So now I'm doing 3 days here at my GP, and then I do 2 days at like a women's health clinic down the road. And on weekends, we do the vaccine clinics for COVID here. Sometimes I do, sometimes I don't. So yeah, that's what I did. And here I am, finally finished everything, which is great. And yeah, I'm really happy with my decision. Certainly it's been a hard time to be a GP during COVID, obviously being on the front line with all that stuff and dealing with people's frustrations. But overall, it's really a wonderful job, and I would be very happy to talk to anyone who is interested in asking more questions. I think that's the end. Oh yeah, this is my puppy. He graduated before I did.
That's good.
Yeah. Does anyone have any questions?
Earlier on in your talk, Alex, that was great, thank you. There was a sort of a slide about business opportunities, and a student who popped on a little bit late just missed that. I think you were just saying that you have business opportunities as a GP. You can sort of take, if you're good at and like to run your own practice and business.
Yes, yeah. So you can, So you've got the opportunity for it to be your own company, or you run the GP clinic. You can run a franchise if you want a GP practice. There's a lot of options if you did want to branch out into not being the sole trader, but to actually so I rent a room here and work as a sole trader, but actually being the practice owner. So yeah, that's just, if you want to do that, it's relatively easy to do. You just have to buy a building and set it up. It's hard work, but you can do it. Just buy a building. Yeah. Yeah, awesome. It's pretty easy. Just go for it. Excellent. And so then next question is, how did you find when you became a GP trainee, did you find that 2 years in hospital made you feel that you were ready to be sitting in an office and sort of conducting sort of initial on your own consultations? And also, if you don't feel ready, can you delay that? And then also, when would you recommend doing, if you wanted to be a special interest GP, do you do that during your training or after, or is it sort of just an open slather, do it when it suits you? Okay, so the first bit, the thing about being a resident is that you are like a glorified secretary realistically. Like, I don't know if you guys have done hospital rotations yet, but the residents are just like following around the ward round, and they'll be told to do notes or to write forms or whatever. You don't get a lot of independent decision making as a resident anyway. So if I was asked this question actually by someone else recently, a student, and I think if you know that it's what you want to do, you just start. It is going to be a steep learning curve when you start anyway. It's very well supported. You get like, you know, 1 patient an hour, 2 patients an hour, you get to slowly work up to it. If you can get some sort of registrar job at the hospital because you're not quite sure yet, then yes, you would get a bit more practice, you know, seeing your own patients by yourself and having to make decisions. But the thing is, it's probably never going to really reflect what GP is actually like. And it's just a matter of diving in and kind of getting to it. I think if you know you want to do it, you just start and get it done. The hospital training is helpful if you do the right rotation. So ENT, like ear, nose and throat, was a fantastic rotation to do for GP because you see that stuff all the time. You know, peds, very helpful as well. Emergency is also quite helpful. So they're kind of the things that I found were most relevant. The other stuff, you know, it's probably more about learning the processes and how things work in the hospital and in the clinics that can be relevant to you when you're wanting to refer in to that system, but actually the day-to-day work is probably not very relevant. So yeah, for me, because I knew I would just get it done. If you are not, so I think the second part was if you're not ready and you want to wait longer, that's fine. So you can just stay on the GP program and tell them you want to do extra hospital years, or you can sit your exam, just sit your exam later when you feel ready that you want to start. At the moment, there's not enough general practice trainees. When I went on, it actually was a bit more competitive. So some people did miss out, but at the moment, not many people are really missing out. So there's no real kind of impetus to do it quickly if you're not 100% sure. What was the last one? Oh, special interests.
Yes, yep.
Yeah, so I knew that like I loved that stuff. I knew that I didn't want to be doing like diabetes, heart disease, like that kind of chronic health management stuff that much. It's just not really my area of interest. Like I mean, I learned about it for my exams and I like knowing about it, but day to day, I prefer to be doing other stuff. So I was like, you know what, I want to be ready to be able to, as soon as I'm fellow, to be able to get this second job and do other things. That was just what I wanted to do. You can do that stuff whenever you like, those extra qualifications. I just thought it was a good time. And just because I could train part-time, I decided I may as well get it all done. And so my studying was done, but that's very much up to you.
Perfect. And I think we might need to move on to our next talk now. Andrew, your question is, I think the pros and cons of going GP or ACRM come down to really your sort of interest in rural medicine. And there's plenty, I think, on the sort of website about that. But if you want a more specific answer, then I can ask Alex if we can send something directly. Would that be okay, Andrew? Cool. All right.
Yeah, I think you're right. Like, I don't know a huge deal about the ACRM pathway anyway. The exams are different. The college is a bit different because I did RSCGP, but yeah, it is mainly about rural versus, you know, urban medicine, but there's heaps online about that for sure.
Perfect. Excellent. Thank you so much.
That's okay.
And if you guys have anything more, feel free to email me as well if you have any more questions, and I can sort of maybe send them to Ali sort of afterwards and see. But that was awesome.
No worries. Thanks so much for having me.
Great. And I think we have Lisa online now. Are you able to?
I think you just have to let me share my screen.
Okay, perfect. I will.
All right, I will stop sharing my screen.
All right, yeah, I think that's the difference, isn't it?
Yeah, all right. Bye, everyone.
Thanks, Ali. Are you able to share your screen, Lisa?
Yep, just setting it up.
Perfect. So while Lisa's doing that, I'll just introduce her to everyone. So Lisa is, she grew up building Lego and Meccano, sewing cross-stitch and loving puzzles and playing Operation. So she realised she had a passion for musculoskeletal medicine when she completed her physiotherapy degree and finished first in her year. And then as her goal had always been to go straight on to medicine, she did, and managed to complete her MBBS at University of Queensland in 2013. Ever since she first entered orthopaedic theatre at the kids' hospital, she realised that that was where she wanted to work. And she was able to get onto the training program after 3 years as a PHO within the orthopaedic surgery field in Brisbane. So she loves her job, and also is enjoying a change of pace currently because she's on maternity leave with a baby girl. But will be returning to training at Greenslopes Hospital next year. Her long-term goals are to be an upper limb surgeon with an interest in microsurgery and shoulders. But she would like to take on a role of leadership, and I'm sure she'll be a force for change within the orthopaedic world, as she's already been in the medical world to date. So thank you so much for your time, Lisa.
That's all right. Sorry, this is the first time I've shared my screen, so just let me know if it's working, and I'll start the slideshow.
Yep, that's perfect.
Great. All right, so thanks for that introduction, Rachel. It's quite an honour to be asked to talk, and I'm not sure how many people are listening, but I hope that you find some value from the talk. There's a lot of, I guess, chat about orthopaedic surgery during medical school, and when you become a doctor, you know, we just know about bones and that's all we care about. I think maybe that used to be the case, but certainly in my experience, things are changing. Orthopaedic surgery is becoming more diverse, and I think if you talk to many of the orthopaedic consultants, they actually do care a lot about their patients and not just bones. So I just wanted to play a short video first that's actually from the AOA website and was part of their, I guess, initiative to help people to understand what orthopaedic surgeons do day to day and just why and sort of what reward we get out of being an orthopaedic surgeon. So I'll just play that quickly and then we'll go into more about me and how to actually become an orthopaedic surgeon.
Dear Doctor, I don't know if you know just how much you have moved me.
So I wanted to tell you in my own words.
I'm so grateful to you. You made my pain go away, and I can walk, run, climb, and crawl.
You got me back in the game. No one's gonna catch me this time.
You got my daughter on her feet and made her face light up again.
You think you give me back my hips, but really you give me back my moves.
These legs are steel springs now. They're going to blaze a trail and conquer mountains.
You made it possible for me to be the world's best man. Well, according to some little people I know.
I didn't really know what an orthopaedic surgeon did, but I know you made me stronger than I was before.
I didn't think normal life was possible for me. You gave me that. Turns out, normal life is extraordinary.
Great. So thanks for indulging me with that video. I really love that video. Every time I watch it, it hits me in the feels. So I hope that other people enjoyed it as much as I did. So in terms of how I chose to do orthopaedics, it was something that I knew that I wanted to do during medical school. I'd done physiotherapy coming out of high school, and I really enjoyed it. I didn't necessarily know at that stage that I was going to do orthopaedics. I really loved sort of the developmental pediatric side of things and thought that maybe I would do pediatrics or oncology even. But it was really during med school that I realized that I really loved sort of learning about musculoskeletal anatomy. And I loved that from my physio years, I understood and knew about the biomechanics of how muscles work and how, you know, the body achieves motion and makes it possible for us to do day-to-day activities. And I think just in my experience in med school, I found that a lot of people don't really understand it. You know, we have PBL tutors who are GPs and other specialists, and when it came to the orthopaedic PBLs, a lot of their knowledge was lacking. And I think it's not taught well in medical school, and unless you actually do orthopaedics, you don't actually pick up the skills and the knowledge just by doing other rotations within the hospital. You learn a little bit about it during ED. If you do an orthopedic rotation, you learn a little bit, but a lot of the time your job is, you know, being the intern or the JHO, making sure that the patients aren't sick, and not necessarily always getting to theatre or getting to clinic and getting that exposure that you get as a registrar in orthopaedics. So I guess I made that decision quite early on, and that made my years as a doctor very streamlined in terms of getting to where I wanted to be. It still takes a long time. I'm still a registrar in my 3rd year of training, and I'm 8 years out of medical school. And, you know, that's actually considered quite quick these days. So it does take a long time. And I think if you are not 100% sure that that's what you want to do straight from med school, then it's going to take longer, and you just have to accept that. Doesn't necessarily mean it's not for you, but you just have to be aware that it's going to take you some time. So I did my internship at the Princess Alexandra Hospital, and I started on orthopaedics. It was definitely my busiest rotation as a junior doctor, but I loved it. And I, you know, made the effort to get to theatre, to get to clinic. I was often there, you know, from 6 a.m. till 8 p.m. at night. But that's just what I had to do to be able to get to clinic and get to theatre and get those experiences and not just be stuck on the ward managing patients. I quickly went on to become a PHO, and first of all went to QE2 Hospital, which is a little bit less stressful and less busy than the PA, and where I thought I would be sort of, I guess, safer starting out, not necessarily knowing much and being quite junior. In terms of sort of starting out as a PHO as only a 2nd year doctor, a lot of people would say, you know, why did you do that? Did you feel ready? I guess I definitely knew that I wanted to do orthopaedics. And like I said before, you don't necessarily learn orthopaedics doing any other specialties in the hospital. So for me, it was all about sort of just getting in there and starting to learn about what I needed to know about and getting the experience. It was definitely a steep learning curve, but I think it would be a steep learning curve whenever you start. I don't think doing more years in the hospital would make you sort of more ready. But obviously that's a personal preference. And if you're not quite sure that orthopaedics is definitely for you, then I would definitely recommend doing some extra years in the hospital, because we'll get down sort of to that path or to that part of my talk, but having a backup is something that you have to consider being an orthopaedic registrar. And if you've only done an internship and then just been an orthopaedic PHO, you don't leave yourself with very many options. So in my first PHO year, I managed to sit the GSSE. I did all my surgical courses, and I published a paper that I've been working on since internship. And I also managed to get married 4 weeks after sitting the GSSE. So it was a very busy year. I think we also bought a house that year. So I don't like to do things by halves. I then went to the Princess Alexandra Hospital as a PHO and started on 4 months of night shifts straight. That was probably the worst time in my life. 7 days of nights and then 7 days off. It's lovely having a week off, but doing night shifts for 7 days straight for 4 months when you've just started at a new hospital, it doesn't lend itself well to meeting people and, working as part of the team or necessarily knowing how the systems and processes work, and it can be very isolating. You're there by yourself all night trying to make decisions, deciding whether or not to call your boss in the middle of the night and wake them up. Are they going to be unhappy with me for calling? Are they going to be unhappy in the morning if I didn't call them? It's quite a sort of, it takes a while to get used to how to make those kind of decisions, and that's what being a PHO is about. I then went on to Ipswich Hospital and did 2 years as a PHO there. It was more, by that time, like I said, I done some research, I'd done all my courses, I had gained some experience, and really those 2 years for me were about improving my surgical skills and making sure that I was capable of doing operations. As a PHO, you are doing operations independently. It all depends on your competence and your confidence. And these days things are a little bit more supervised than what they traditionally were, but certainly there is an expectation that you're able to complete a lot of operations independently before you get onto the program. And your knowledge needs to sort of support that and back it up. So I was lucky enough to get on to the training program in my second year at Ipswich Hospital. I applied the year before but didn't manage to get an interview, and the next year I got an interview and managed to get on. So I was very lucky. I think there was only 2 people in my year who initially got onto the program, and later on a few extras were added as sort of second round offers, but you know, certainly it's a tough slog to get onto the program. And I was competing against people who had been PHOs for about, you know, up to 8 years, and some of them have still managed to not get onto the program. Some are still trying. Some have decided that it's just not going to happen for them and gone and done other things now. So in my registrar years, I was at QE2 Hospital again to start with, which was lovely to go back to. I then did the PA hospital as well. I sort of repeated my PHO years, I guess. And I was at the kids hospital at the start of this year, which was a really good experience. And I was actually pregnant during that time. And I'm now on maternity leave for the 6 months, second 6 months of this year. And then I'll go back to Greenslopes Hospital, busily studying for my exam. And hopefully I'll sit my fellowship exam in the second half of next year while I'm at the Prince Charles. And then I'll have 1 more year of training after that, which I don't know where I'll be sent. It might be that I get sent rural in Queensland somewhere. And by that, I mean sort of regional, either Cairns, Townsville, Mackay, or Campton, Toowoomba, Sunshine Coast or Gold Coast, or I might be lucky enough to stay in Brisbane. I just have to wait and see. And that's, I guess, Alex was alluding to the fact that in GP, you're very in control of, you know, your pathway and where you are and when you are where you are. Certainly in orthopaedics, we don't have that ability to dictate where we'd like to go or where we'd like to be. We find out very late in the year where we're going the next year. So I think you find out usually in sort of September, October, sometimes even as late as November, where you're starting in February. So it doesn't leave much time to plan. In terms of what a day looks like in orthopaedics, so like I alluded to, it is a very early start. We probably are the earliest starting specialty. You know, it means you get a car park. You don't have to fight for a car park anytime. Usually you can get your coffee quickly in the morning, but you know, you have to be someone that likes getting out of bed and getting ready for work and sort of being ready to go at, you know, 6:30 or sometimes even earlier. So usually the day starts with doing the ward round. You know, the poor residents have been there usually 15 to half an hour earlier than us, getting the list ready, and the ward round is pretty quick. As you've probably experienced on your rotations, we don't take all day to do the ward round like the medical registrars. The ward round has to be done in half an hour. And certainly as a resident, you learn very quickly that, you know, that's the sort of time that you're guaranteed to be with your registrar and to be able to ask questions. So you have to be thinking right from the start, you know, what am I going to be aiming to do today with these patients? Who's sick? Who do I need to know, you know, what they needed to be discharged on? What questions do I have? And how do I need to sort of plan my day? Because it may be that the registrar then goes to theatre and is tied up for the rest of the day. You can always obviously scrub in or get into scrubs and go and talk to them, but they're distracted. There's usually a trauma meeting that follows the ward round, and that's where all the new patients are discussed. New x-rays are sort of put up and people are quizzed on them. There's often sort of teaching as part of that meeting. and you hear the stories of the new patients and what the plan is. And if the boss has already seen the x-rays, then the plan might be clear. However, if the boss is sort of attending the meeting, it might be the first time they've heard about a lot of these patients, and plans could be sort of being made during that meeting. Usually, if things are going smoothly and it hasn't been a particularly busy night, there is time for coffee at that point. And then it's off to either clinic or theatre, depending on what the day sort of brings. As a registrar, it's probably a 50-50 split in terms of how much time you spend in clinic and how much time you spend in theatre. As a PHO, you probably spend a bit more time in clinic, particularly doing fracture clinics and things like that. But you still do spend a fair sort of time in theatre as well. And I think, most jobs I've worked, it's been a bit of a 50-50 split of the week. So the morning clinics always start at 8:30, and then the afternoon clinics are at 1. You try and get some lunch between them, but sometimes you might only get a 5-10 minute break. They tend to run late, the clinics, and usually clinics are done by sort of 5 o'clock, but some jobs you hear that people are still there till 7 p.m. and doing another ward round after that. So it can be a busy day. It depends on the hospital. It depends on how well things are run, how the clinics are protected. But it can be fairly busy. If you're doing a fracture clinic at the kids, I think we see about 80 patients in the morning and 80 patients in the afternoon. And patients are in and out within a couple of minutes, which can be pretty hard to deal with sometimes. Theatre day, every day is different. It can depend on whether you're doing upper limb, lower limb, spine, whether you're the on-call registrar, whether you're doing a trauma list. But I guess that's part of why I love orthopaedics, that every day is different and there's so much variety in the operations that we do. Certainly there is a lot of, draining pus and abscesses, doing washouts, but I think the more experience you get, the more variety you're able to sort of get in the theatre cases. And I certainly love doing a wide variety of operations. On call, so typically at most hospitals as a registrar or a PHO, you're on call sort of one night during the week, and then it's one weekend, usually in 4, usually once a month. It depends on the hospital. If there's a nights cover at the PA, it's probably, I think Cairns has nights PHOs as well. We do that run of nights that I said I did in my second year of PHOing. But most of the other hospitals have a 24-hour person on call, so you're receiving phone calls at night, and potentially coming back into the hospital at night time, depending on what the issue is, and that can be pretty busy and pretty fatiguing. Sometimes you're getting calls every hour, having broken nights, and sometimes the calls you're getting are very dubious as to whether you did need to be called, and can be a bit frustrating, but that's just the nature of the job and you have to sort of deal with that. The weekends are busy. So my husband's an ENT reg, and when he does a weekend, he goes in, does a ward round maybe for an hour or so, and then he comes home. We can plan to go out for lunch. We can plan to have people over for dinner. He might get a couple of calls. He might go back into the hospital once or maybe twice in the evening, but he can still sort of enjoy his weekend. When I'm on call, it's totally different. I'm there on the Friday evening, usually till at least 10 p.m. I go back at 7 on the Saturday, and I might not come home until 10 p.m. again on Saturday night, and then repeat that on Sunday. So it's definitely full on, and it takes a lot of sort of commitment to and I guess you have to go into it eyes wide open, knowing that that's what to expect. So in terms of the pros and cons, I guess the things I love about orthopaedics are the variety of practice, the fact that you have skills that others don't have, the fact that it is highly technical, it's logical, it makes sense. You can sort of go into treating a patient and knowing what you're aiming to achieve, what you're aiming to improve, and you know, hopefully they're going to come out of what you've done with an improved quality of life. I find it extremely rewarding. It's not like a chronic disease as a medical specialist where you give someone tablets and you see them again in, you know, a few months' time and see if their sugars have improved or their blood pressures come down. It's immediate satisfaction. It's immediate, you know, either fixing a fracture or getting rid of someone's arthritis or repairing, you know, a structure that's been damaged. We do treat people right from first day of life up until the end of their life, which I guess it's similar to GP in that respect. Certainly in medical specialties, you're either a pediatrician or an adult medicine doctor, whereas in surgical specialties, we see everyone, and we do rotations through both kids and adults hospitals, and certainly in the regional hospitals, we see the full spectrum. And you do get to use your hands, which is something that I love. It's not just about using your brain. We do obviously need to use our brains, and, you know, orthopedic registrars and consultants usually are very intelligent. They're just intelligent in a different way. But certainly you get to use your hands every day. And I'm someone that really enjoys, I guess, being dexterous and completing tasks that involve that sort of hands-on capability. The cons are, it's obviously a long road. Like I said, I'm 8 years out of medical school and I've still got probably 2 years of training to go. It does take a long time, and you have to be aware of that. During that time, you obviously have early starts and late finishes, and you're working very hard. There can be a lot of burnout. You can be tired. You can be anxious. You know, to operate on someone independently when you don't necessarily feel like you have the skills or you're doing it for the first time, it can be very anxiety provoking. A lot of people would agree that they have a bit of imposter syndrome sometimes. You know, you could be very capable of doing something and you still feel like, oh, you know, I wish I wasn't here by myself doing this. And certainly as a PHO, I think often you can feel undervalued and underappreciated because you're not one of the trading registrars. You're not getting protected teaching. You know, you haven't, I guess, proved yourself to be on the program yet. And although you're working sometimes harder than the registrars, you are not necessarily granted the same luxuries and the same, I guess, ability to say, oh, yeah, you can start late or you can start early, or, hey, do you want to come and do this great case? You still are picking up the pieces and doing the fracture clinics and, you know, saying yes, I'll be available to come and private assist you after I've just done my night shift for, you know, 12 hours, saying yes to being available on the weekends and, you know, picking up extra bits and pieces along the way. I guess there's an uncertainty as to whether you will get accepted onto training one day, and it doesn't necessarily mean that you're not good enough. A lot of it is luck. A lot of it is being in the right place at the right time. A lot of it is a numbers game, and you know, you have to, I guess, go into it knowing that. And like I alluded to, your skills are not necessarily translatable. So either doing some other rotations before you start orthopaedic to facilitate having a backup, or just knowing how you're going to manage if you do decide that orthopaedics is no longer for you. So in terms of selection, so I'm not going to go through it in great detail because they seem to change the selection requirements every year. But the website down the bottom is where you can sort of check what the current selection requirements are. Broadly speaking, there's a CV, there's references which are department-based. It's not like you're going out and saying to a certain consultant, oh, can you give me a reference? It's every job you've done, they, as a department, meet, give a department-based reference on you, and then that I guess gets compared to everyone else that they're giving references for. that year, and then there's an interview. So the CV is very points structured. So it's not just you saying, oh, I've done all these things. It's you get points for certain things. And if they change the rules and one year, you know, you're getting a point for something and the next year you're not, you just have to roll with it and sort of keep up to date with what exactly you are doing to get points. I think at the moment the rules are that you get at least 6 points on your CV, which is, you know, a combination of research courses, doing the GSSE, and things like masters or PhDs. And then if you meet that 6 points, you are considered. They look at your references, and if based on your points and your references, you're in the top sort of so much percent, then you get given an interview, and then it's pretty much based on your interview. 75% of your score is based on your interview, and I think 25% on your references, and that's how they decide who gets on. In Queensland, there are a lot of PHOs. There's 140, I think, roughly, and last year about 41 got an interview, and then 12 were successful to get onto the training program. So you can see that it's quite high numbers and it's quite competitive. In terms of the training program, what does it involve? So it used to be a set program, which is what sort of general surgery and some of the other surgical specialties are like. They talk about set 1, set 2, set 3, set 4, and set 5, and it's a 5-year program. Orthopaedics is no longer like that. So we're a competency-based training program. You do 12 months of introduction to orthopaedics, and you sit your orthopedic specific primary during that time. You have to complete certain operations and be signed off as competent, and then you can progress to core orthopedics. Core orthopedics is sort of roughly between 2, 3, and 4 years, and you complete some more competencies based on each of the subspecialties and sort of progress through ticking things off. You get to the point where you've ticked enough of your modules off, and then you're allowed to sit your fellowship exam. And then if you pass your fellowship exam, you then transition into the last phase of training, which is 12 months of what they call transition to practice. And so during that 12 months, no one's actually done it yet, but what I believe happens is that you do some webinars. There's a bit more training in terms of how to start as a consultant, what to do your fellowship in, and sort of how that works. And, you know, if you are thinking about going into private practice, how to set up billing and how to sort of go down that path as well. There's also a focus on training, so being taught how to train other registrars as you become a consultant, because I guess they understand that it doesn't necessarily come naturally to everyone, and that's part of what that year is, I guess, targeted towards. So like I said, it's now competency based. There's a couple of examinations that you do during your training. The fellowship examination is quite involved. People study for 2 years, you know, 4 hours after you've done your day of work every day, and 8 hours each day on the weekend is what I'm being told at the moment, which is quite daunting. And they are sort of saying that flexible training is possible, that you can do part-time training. I'm obviously having 6 months off for maternity leave at the moment, which is was very easy to organise, and certainly, you know, I didn't have any troubles asking for that time. Then, like I said, after you've done that transition to practice year, most people are going off and doing a fellowship, and that can be 1 to 2 years of subspecialty training. You can sort of do it in whatever you feel like you want to. Oftentimes you're thinking about what hospital you're going to return to as a consultant, and you might have a discussion with them as to what you can do to sort of help the department, you know, where's the area of need, that kind of thing. Or equally, you can just decide, hey, no, I really love doing spine, and I want to, you know, do that in my fellowship, and I guess decide whether you are going to start out as a consultant in private practice after you've done your fellowship, which I think you would have to have a fellowship to do that, at least in Brisbane. But certainly you could get a job as a consultant in some of the more regional and rural areas as an orthopaedic surgeon, having just done training. But I think most people expect to do a fellowship for at least 12 months these days. Are there any questions?
Thanks so much, Lisa. That was very good. And I think it's one thing that we've seen a lot of change in. That's a new program, isn't it? Which I think will hopefully make orthopaedics definitely a better positioned specialty to spruik itself. You know, not losing that idea that orthopaedic surgeons may not be very intelligent. I think hopefully will be something of the past, because they're certainly very, very clever doctors. Couple of questions in terms of the sort of medical students at the moment, and many people watch these videos as well afterwards, and often one of the things that they like to know is what can they do to best place to position themselves as well as possible during their, for example, final year and or intern and JHO year, and so then top tips around that for our students.
I would really recommend I guess knowing your anatomy. And I guess we all talk about how medical school doesn't necessarily prepare you as well as what it could in terms of learning anatomy. And, you know, part of that is just because there's so much to learn and you can't examine everything. And if something's not examined well, then you don't necessarily bother to go and spend so many hours studying your anatomy. But I think if you don't have a good sort of anatomical basis behind you, it's going to be really hard as a PHO going and starting orthopaedics, because at that point you are sort of past the point of learning the anatomy. You now have to be learning how to do operations. And so if you don't have that sort of strong basis behind you, you are definitely not going to perform as well as someone who does. You know, you'll make mistakes, you won't know where the nerves are, what to look out for, that kind of thing. So I think definitely, you know, taking your own time to learn your anatomy properly, and then just you know, keeping an eye on that website where it talks about selection to training, and sort of having a look at, do I need to start you know, enroll in a master's when I'm an intern or a JHO? Do I need to start signing up to do some research papers? You know, how am I going to start working away at doing these things that get me points, so that you know, when I come time to apply, I'm ready and I'm not going to waste I guess years of my life sort of getting ready to sit an interview and not be prepared properly. I think once you get to apply, you really have to back yourself that you have enough points to be considered, and that you're in the right sort of place to be accepted, because they do have the sort of 3 strikes, and that's it in terms of applications now, which is not something they had when I was going through, but I imagine it's quite daunting when you're a PHO.
And sort of speaking to that too, if you're doing research, that's transferable, isn't it? It's something that can be put on other CVs for other applications.
Yeah, definitely. And a lot of the, you have to check the website, but I think that a lot of the research doesn't necessarily have to be, you know, orthopedic specific. It has to be sort of roughly something that could be, you know, related to orthopedics, but you could certainly do something a bit more like along the sports medicine side of things, or anatomy, or less clinical, I guess, and that would count towards orthopedics as well.
And you did some research in intern. Did you approach someone specifically to get orthopedic research, or was that something you'd done previously with physio and things?
No, I think in my first rotation as an intern, I spoke to one of the senior consultants at the PA and said, hey, I want to do orthopedics. Well, he sort of already knew, because I'd done a rotation as an elective when I was a med student there as well with him. But I sort of went up to him again and said, look, I'm serious about this. I want to get some research behind me. And I guess he helped me to find a project. And then it was very much up to me to get that project done. Yeah.
Perfect. And then just one final question, I think. Yep. In terms of all the work that you've gone through to become a trainee and then to get through the other side and become a surgeon, are the job prospects everything you sort of hoped they would be?
Yeah, I think so. So I believe it is quite competitive to get a consultant job in Brisbane, but I guess I'm lucky enough to already have people talking to me about working at their hospital when I'm done. I'm hopefully going to go back and work at QE2 once I've become a consultant and done my fellowship. But certainly, seeing the guys who are graduating this year, most of them do have consultant jobs lined up within Brisbane, or if not Brisbane, places like Gold Coast or Cairns, which is where they want to end up. And, like I said, there's always the option of going private as well. I think most people do tend to wait a few years before they go private just to get some more experience and exposure, but that's an option. There's certainly a need for orthopaedic surgeons, up the coast, north of Sunshine Coast. And, I still love what I do every day. It is hard work, but I guess once you're a consultant, you can just work a couple of days a week if you want to. And, there is, I guess, more opportunity to be a bit more flexible with your work-life balance once you are a consultant.
Perfect. Excellent. Well, thank you so much for your time and energy today. That was really great.
No worries.
I'm sure.
Thank you.
Thanks.